Hello, my name is Kristen Talbot, and I am the Program Coordinator for the MAVEN Project. Thank you all for joining us today, and thank you to our friends at El Rio for hosting today's session on evaluating short stature with Dr. Root. Dr. Alan Root is a graduate of Harvard Medical School who is a board certified in general pediatrics and pediatric endocrinology. He's an adjunct professor of pediatrics at the Johns Hopkins University School of Medicine and professor of pediatrics Emeritus University of South Florida, Merceni College of Medicine. Dr. Root has served as chairman of the American Board of Pediatrics, Subboard of Pediatrics Endocrinology. He has cared for infants, children, and adolescents with disorders of the endocrine system for more than 50 years. Dr. Root, when you are ready, please start.
Thank you very much, Kristen. It's a pleasure to be here. And we're going to talk today about the evaluation and management of the infant and child with short stature. And this is not what I look like at this time, but this was me earlier in my career with three brothers. The two brothers in the front of the picture, the one on the extreme left and the one on the extreme right, are children with panhypopituitarism, while their 3-year-old brother, who is in the middle, is taller than his 5- and 7-year-old brother. The 3-year-old brother being a child without hypopituitarism. One can define short stature or attenuated growth in several ways. Conventionally, short stature is defined as a length for children under 2 or height for children over 2 years of age, more than 2 standard deviations below, that is below the 2.3 percentile, more than 2 standard deviations below the mean height for age and gender. One can also define it relative to the skeletal maturation in terms of short stature and potential for growth, where length and height are more than 2 standard deviations below the mean for gender-specific skeletal maturation or bone age. In a child whose height still is within the normal limits, normal range on the growth charts, attenuated or slow growth is defined as a growth rate or velocity below the 25th percentile for the child's chronologic age, gender, and, if appropriate, stages of sexual maturation and bone age. There are numerous causes of short stature. Intrinsic short stature indicates that this is a child who has limited growth potential and is short because of factors that may be familial. That is, the child has short parents and grandparents, or in children who have been born small for gestational age, and then in a large group of patients with, quote, idiopathic or unknown causes of short stature. Among the most common types of short stature that one encounters in the pediatric endocrine practice are those patients who have a normal potential for growth, but are delayed in achieving it. They are delayed not only in their linear growth, but in their initiation of adolescent pubertal development. And this is termed constitutional delay in growth and puberty. Far less common, the two intrinsic short stature and constitutional delay in growth and puberty, accounting for the largest number of patients seen in a pediatric endocrine referral practice. But one has to take into account and always be aware of those causes of short stature which are not within the normal milieu. So one can have endocrinopathies in which there is a decreased secretion of growth hormone and its effector agent, insulin-like growth factor 1, decreased secretion of the thyroid hormones, increased secretion of adrenal glucocorticoids, and so forth. Then there are children who have short stature associated with characteristic physical features, as we'll discuss in a moment, and they often represent a given syndrome named after the investigator who first described that particular state. An increasing number of patients are being identified with short stature due to skeletal dysplasia, as we are looking more and more at the genome of intrinsically short children and finding a number of chondrodystrophies that are rather subtle in their manifestations, but identifiable by their variants of their specific genes. Chronic systemic diseases account for a small number of patients with growth retardation and are usually self-evident. And a small but significant group of children have impaired growth due to emotional difficulties. They're hard to pick up, these particular children. Some of the well-known syndromes associated with short stature, with which I'm sure you're familiar, are Turner syndrome, which is associated with 45X chromosome constitution or variants thereon, and those with phenotypic characteristics such as the Noonan, Silver-Russell, Prader-Willi, and so forth. There are a large number of skeletal dysplasias, and then some of the chronic systemic diseases which one may encounter in the short child include celiac disease and chronic inflammatory bowel disease, which may not be self-evident in that they may not present or have any gastrointestinal symptoms, but are identifiable with more thorough investigation, and some of the other chronic systemic diseases. How does one evaluate a child with short stature? Well, as with all medical evaluations, the most important part of the initial evaluation of this child is the history, particularly the medical and family history. In the medical history, one looks for complications of gestation or delivery, or in the postpartum period. One reviews very thoroughly the family history, because often the child will be following a pattern of growth and sexual development similar to that of a family member. One of my most vivid memories is of a 19-year-old who was prepubertal and short, and whom I was convinced had to have a systemic disorder. And the mother kept telling me, and was there because of referral by the primary care physician, which was quite appropriate for a child at 19 to be prepubertal. And the mother kept insisting that this was the way her father had grown, who had told his daughter. And sure enough, after extensive evaluation and follow-up, this now young man began his own pubertal development, had a growth spurt, and had a very acceptable adult stature when he finally achieved it. So a careful history is extremely important, and it's worthwhile believing what the family tells you although carrying a healthy quantity of skepticism and proving for yourself that what is being told you is correct is always an important asset. One wants to look for injuries, particularly head injuries in the short, poorly growing child, or history of illnesses. And then it's very important to get as many past growth measurements and information about pattern of pubertal development in the family, as I've said, and the child, the patient, and to then plot these growth measurements. The physical examination allows us to take careful length or height measurements, and it's essential that the height be taken correctly, and to search for physical signs of abnormalities such as organomegaly or cardiac murmur. And assuming that one has no direction after historical review and physical examination that points one toward a specific diagnosis, screening laboratory evaluation, including a bone age, which estimates the growth potential of the child, as well as the other general studies, sedimentation rate, CBC, urinalysis, chemistries, thyroid studies, and an IGF-1 as an indication of growth hormone status are worthwhile initial studies, assuming one doesn't have a specific direction in which to look. Some of the diagnostic findings in the medical history and physical examination that are of help, as we've already said. The medical history is essential, particularly information about birth length, weight, etc. Earlier growth data, history of pubertal development, previous diseases, injuries, operations, medications, psychomotor development, family history, essential with a family pedigree if possible. It's very helpful to measure parental height. If both parents are available, or whichever parent is available, the historical statements about parental height are only so true. They may not be entirely accurate, and the male ego encourages one to exaggerate, as you all know. And you would also like to know when the parents began their puberty. Physical examination includes careful measurement of height, body proportions, weight, and looking for dysmorphic features, pubertal staging, as well as a general physical examination. These are self-evident, which one would do for every patient. Height is extremely important to measure accurately, which is why I like a wall-attached stadiometer with a horizontal projection at a right angle to the measuring board, which one can move up and down to rest lightly on the scalp of the patient, who is shoeless when being examined and standing erect with this stadiometer, with the head, shoulders, and buttock and heels in contact with the posterior vertical surface. This is really I can't tell you how important it is to take a correct, important height. And this is one of the problems with some of the measuring devices that are attached to scales. Those of you who've used them will sometimes, or not infrequently, note that the horizontal measuring device isn't exactly horizontal. Sometimes it will tilt upward, and you have to be very careful when you're using such a device to be certain that the superior measuring device, a superior part of the measuring device, is horizontal when measuring the height of the individual. There are longitudinal measuring devices for measuring the length of infants, and there are even horizontal measuring devices for measuring the length of older children and adults if one has the resources and space for such an instrument. This is a typical boy's chart with height above and weight below, absolute height versus absolute age, chronologic age. And you can see the normal range in green, and then some of the smaller percentiles in purple and yellow for height and weight. It doesn't do you any good to take a height as accurately as you do if you don't plot it. And it's absolutely essential that you be certain that you're plotting it correctly to height and weight. Equally important is if one can have past growth measurements, one can then plot growth velocities. And this is also very important. And you will note that there are 3 patterns of growth depicted on this particular graph. The major ones are the normal variations, and there is a slow declination in height from early childhood till the onset of the pubertal growth spurt, which varies from by gender, girls beginning their adolescent growth spurt at a younger age than males. But there are some boys who begin their growth spurt early, and other boys who begin their growth spurt late, and those can also be within the normal range and with a appropriate height, adult height achievement at the end of the growing period. How do the bones grow? This is critical. This is a growth plate, and you will note from top to bottom there are different zones. The resting zone is immediately below the end of the long bone, the epiphysis, and here cartilage cells are in a resting state, and with appropriate stimulation from growth hormone and sex hormones, they begin to proliferate. They form columns and enlarge and form a hypertrophic zone, which is then invaded by blood vessels carrying bone-forming cells. So you get a metaphysis, and then below that, you get a bone formation. So this is a typical cartilaginous growth plate. And depending on how many cell divisions the cartilage makes in these growth plates, longitudinal growth plates, will determine how tall that individual will be. This is another cartoon, or a cartoon of the growth plate. And you can see that there are a number of factors that play into how cartilage grows. There are hormones, growth hormone, thyroid hormone. There are mechanisms within the chondrocyte itself, which govern its reproductive or growth rate. Nutrition plays an important role, both over and under nutrition, and there are a number of other signals which come into the chondrocyte, which directs the rate of growth of the chondrocyte, proliferation, the growth plate, and ultimately adult height. One also evaluates sexual development in the child who was being evaluated for growth retardation, staging, utilizing the Tanner stages of sexual development for estimation of sexual maturity. In the male, the stages progress from 1 to 5, prepubertal being a length of a testis, greatest length of the testis less than 2 centimeters, and stage 5 being the length of the testis greater than 5 centimeters. Note that neither scrotal or penile dimensions are used in this classification staging. It's the testicular length, sometimes testicular volume. This takes a little practice and some privacy as you are measuring testicular length, depending on the age of the child. And just in drawing fashion, you can see the small prepubertal scrotum and testes of the prepubertal child, early testicular enlargement progressing through stage 5 or adult sexual development in the male. There is a orchidometer, which allows one to estimate testicular volume. This too takes a little practice, but it works fairly well. Actually works very well. And there are testicular growth charts to allow you to plot testicular dimensions in the male. In the female, one relies on breast development to identify stage of sexual maturation, breast development being requiring estrogen production, and estrogen synthesis being primarily ovarian in origin. We do not have a non-invasive or non-ultrasound method to estimate ovarian volume, particularly in the office. That would be nice. The first sign of adolescent sexual development in the female is subareolar breast budding. That is the diameter of the breast bud, which is a small bit of tissue below the areola, is less than that of the areola. Stage 3 is when the amount of breast tissue extends beyond the areolar border. Stage 4, which not all young ladies go through, is when the areola forms a secondary mound above the plane of the breast. And stage 5 is when the areola recedes and merges with the plane of the breast. As I said, not every young lady goes through stage 4, or at least is observed to go through stage 4. Some apparently going from standard stage 3 to 5. But please note that breast volume is not utilized in staging of breast maturation. It's breast configuration. And here is a depiction of breast development and sexual hair growth in the female, from breast budding to the formation of a areolar mound to the adult contour. In the female, Tanner stage 5 is the usual end of pubic hair growth. In the male, with continued testosterone exposure, the pubic hair extends up the linea alba to the umbilicus to form a diamond-shaped escutcheon, as opposed to a triangular escutcheon in the female. And so these are the stages of sexual maturation, from none, which is stage 1, to the earliest appearance of sparse, fine, darker than normal body hairs at the base of the phallus, which are very hard to photograph, but which one can see. Stage 3 is when you have long, dark, curly sexual hair at the base of the phallus, or mons. Stage 4 is when pubic hair is in the form of an inverted triangle over the mons pubis. Stage 5 is when sexual hair extends to the medial thigh regions, and stage 6 is when sexual hair extends to the umbilicus in a diamond-shaped scutcheon. And here you can see this illustrated in the male from earliest Tanner stage 2, which is very hard to see, through 3 to 5. And here are photographs of breast development and male genital development and sexual hair development in male and female pubertal subjects, as recorded by Dr. Tanner. Well, having done the history and the physical examination, it is now essential to try to determine what is the growth potential of this short child. And this is best established by looking at the skeletal maturation or bone age of a child. And here, just arbitrarily selected as a male for 2 years of age, and the various changes that are taking place in the hand of this child at 2 years of age, as you can see in the yellow writing, where some of the ossification centers in the digits and so forth are being formed. Until you, and then one can use the Wilkins hemiskeleton bone age graphs to identify, other than in the hand, which skeletal areas are becoming calcified, from the shoulder to the elbow, to the pelvis, to the knee, and to the foot, and through 5, and then that goes through 12. And then you can see, returning to the hand radiograph, the changes that are taking place in the 10-year-old male in terms of epiphyseal development and early fusion, until you get to an adult stage when there are no open epiphyses in the hands. Here are depictions of the growth patterns of the average male, the boy with constitutional delay in growth and development, and the boy with idiopathic short stature. Actually, this could be a boy or a girl, but this is male. So you will note that the average child, quote unquote, and no child is average, every child is superior. The child is growing along the 50th percentile in height. In the boy with constitutional delay in growth and development, growth rate may be normal, but height is below the 3rd percentile or below the 5th percentile. But there is a growth spurt in this child at 16 rather than at 12 and 13. And ultimately, height is within the normal range, as opposed to the child with intrinsic short stature, who is small and stays small into adulthood. And one can look at growth rates, as the previous slide depicted absolute heights. This depicts growth rates, those who grow average in the middle, those who grow early, and those who grow somewhat later. Looking at some of the disorders that are associated with growth retardation, here are 2 children with growth hormone deficiency. One due to an abnormality of the gene GH1, which encodes for growth hormone. So this patient has a lack of growth hormone production and would be expected to respond to the administration of growth hormone with an increase in linear growth rate. The problem being that such a child will often develop antibodies against growth hormone, which will neutralize the growth accelerating effects of growth hormone in such a child. The other child, a little bit older, but who looks very similar, has an abnormality of the growth hormone receptor, not of growth hormone production. This is not a child who would be expected to respond to growth hormone, but might to other growth promoting agents such as modified androgens, but not necessarily to a normal adult height. But the frontal bossing, the blue sclerae, the depressed nasal bridge, the small maxilla, very characteristic of the child with growth hormone deficiency. And if you will recall the first slide in this presentation, after the title slide, there were the two brothers with hypopituitarism who had faces very similar to these two children. One of the studies that one would carry out in a patient with growth hormone deficiency in an attempt to identify the cause would be a CT scan or MRI. And one of the most common findings in such a patient will be a patient with an abnormality of the pituitary stalk, which connects the hypothalamus to the anterior pituitary. Under normal circumstances, the anterior pituitary and the posterior pituitary are both found in the sella turcica, but in this child, the posterior pituitary is identified by the bright spot near the long arrow instead of being in the sella near the thick, shorter arrow, has failed to descend into the sella. This patient does not have diabetes insipidus, as this ectopic posterior pituitary is fully capable of making antidiuretic hormone as required. But without the pituitary stalk, the hypothalamic factors which regulate anterior pituitary function, the releasing factors, cannot reach the anterior pituitary, and therefore hypopituitarism ensues. These are some of the abnormalities that are seen in patients with insults to the growth hormone IGF-1 axis. You can have GH deficiency, which may be acquired due to a tumor or trauma, congenital, as we've seen, associated with a structural defect. There are now a large number of genetic variants which are associated with growth hormone deficiency and pituitary cell differentiation and pituitary development. If one has an abnormality of the growth hormone receptor, one can have growth hormone insensitivity. One can have abnormalities of the IGF binding protein system and the genes that regulate IGF-1 release, such as PPA2, which we'll talk about. And one can have primary abnormalities of IGF-1 itself, or an abnormality of the IGF-1 receptor leading to IGF-1 insensitivity. Here is a typical patient with acquired hypothyroidism, a 13 or 14-year-old boy with short stature, husky build, long, a wide, dull face, and if his mouth were open, you'd see a prominent tongue. This is a typical child with hypothyroidism, primary hypothyroidism. This is a typical child with a very common genetic disorder, known as Turner syndrome, most commonly associated with the loss of one X chromosome and a 45X karyotype, but also associated with variable abnormalities of a second X chromosome, such as deletions or isochromosomes. There are many systemic features of this syndrome, including typical facial features, abnormality of the heart and kidneys, specific abnormalities of the bones, and so forth, and most easily identified, one, clinically, and two, by chromosome karyotype. Here we see twin boys, one of whom is normal and one of whom has achondroplasia. These are fraternal twins. Achondroplasia is due to an abnormality of the fibroblast growth factor receptor. And we'll see in a later slide how this is now potentially a manageable problem. And the fibroblast growth factor receptor 3 is involved in the binding of fibroblast growth factors to their receptors on the cell membrane of the chondrocyte, which in turn leads to chondrocyte differentiation, proliferation, hypertrophy, synthesis of cartilage matrix, and so forth. In patients with achondroplasia, the FGFR3, the third form of the fibroblast growth factor receptor, is mutated and is interestingly mutated in that instead of having a loss of function mutation, it has activating mutation. Well, an activating mutation means that the receptor functions in the absence of its binding ligand, that is the fibroblast growth factor, but it is unregulated. So in patients with achondroplasia, fibroblast growth factor receptor 3 functions independent of its ligand FGF, and it causes chondrocyte differentiation, proliferation, hypertrophy, synthesis of cartilage matrix, it depresses those functions, but accelerates terminal differentiation of the chondrocyte such that fusion of the epiphysis occurs. Now, we'll see in a minute that another agent called C-type natriuretic peptide, or CNP, also works in the chondrocyte. And under normal circumstances, it binds to and activates natriuretic peptide receptor type 2, NPR2, which stimulates a signal transduction pathway that inhibits the FGFR3 signal transduction pathway cited in the first paragraph. And a long-acting analog of C-type natriuretic peptide called vosoritide has been developed that, working through NPR2, can inhibit the accelerating effects of FGFR3 on chondrocyte differentiation, permitting chondrocyte differentiation and proliferation and matrix synthesis to proceed in patients with achondroplasia, increasing adult height to a significant extent, although not all the way to normal. And the biochemistry which underlines this, and this slide's a little hard to see, and I apologize, but if you look at A, the activated FGFR3 receptor, that is the mutated FGFR3 receptor in patients with achondroplasia, initiates its intracellular transduction pathway which goes through a number of steps and then leads to the proliferation and maturation of chondrocytes and premature cessation of growth. On the other hand, when you have this NPR material, it stimulates a pathway that interferes with the pathway stimulated by the FGFR3 receptor, autonomous FGFR3 receptor, permitting cellular proliferation and maturation in the chondrocyte level to proceed with an increase in growth plate size and ultimately with in height. So this is an end product. I mean, I think this is remarkable because when the investigators were studying these intracellular signal transduction pathways, I'm sure they had no idea that their findings would ultimately prove to be of therapeutic value in patients with achondroplasia. I mean, that's true over and over again with so many of the scientific discoveries with which we now have. But so science for the sake of science is well worthwhile because one never knows specifically what these findings will lead to. So here are some.
I just want to jump in real quickly. About 15 minutes left. Just giving you a quick time check.
Well, I only have another 430 minutes of talk.
All right.
I mean, that's never going to work. They're going to be late for their next clinic. Well, I'll go. I'm talking as fast as I can. Anyway, here are some of the abnormalities associated with short stature, which are related to gene variants, include disorders of the growth hormone axis, disorders of the growth plate themselves, and disorders of the cartilage extracellular matrix. Some affecting intracellular pathways, some associated with syndromes, and so forth. And every day you wake up, there's another abnormality whose gene variant has been identified. So I guess the answer to that is don't go to sleep. But no. And these are some of the studies that one would ordinarily do when searching for a cause of short stature that was not previously identified as being due to growth hormone deficiency or thyroid hormone. You can look for a shocks, a copy number variation for Larry-Weill dyschondrosteosis, abnormalities of FGFR3, which we've talked about, abnormalities of the GNAS and PROP1 genes, and so forth and so on. There are a large number of genetic tests available now for the evaluation of the child with short stature. Some of the genes variants that have been associated with isolated short stature phenotype, that is without typical abnormalities that might make you think of achondrodystrophy and so forth, are those that involve the growth hormone receptor, the SHOX gene, growth hormone itself, IGF-1. There are some, and we'll talk in a minute about some of the other genes down the list there. Evaluation of the child with short stature begins, of course, with a history and physical examination. And if you suspect that the child has constitutional delay in growth and development, observation is appropriate. If the child does not proceed with growth, or there are physical, historical, or laboratory findings suggesting that the patient does not have constitutional delay of growth in adolescence, you might suspect a skeletal dysplasia, in which you will do a skeletal survey, perhaps followed by a gene panel. If the child does not have an identified skeletal dysplasia, you start to look for monogenic disorders, growth hormone deficiency, or the novel genetic abnormalities. Here we look at a child with idiopathic short stature as previously defined. That is a patient with short stature for whom no familial or other factors can be found. This is what how a child with idiopathic short stature will typically grow at or below the 3rd percentile. If you look at a child with growth hormone deficiency, you will see a slow growth rate such that the child's height falls progressively below the 3rd percentile, with a dramatic acceleration of growth into the normal range, usually when the diagnosis of growth hormone deficiency is made and treatment with growth hormone is administered. So returning to idiopathic short stature, it is by definition a height more than 2 standard deviations below mean for age and gender, may be with or without small for gestational age, can be familial or non-familial, but it is not associated with a recognizable syndrome or systemic disease. By definition, bone age is equal to chronologic age. And currently, many such patients undergo whole genome sequencing, and we'll see why, but it requires normal whole genome sequencing may or may not require a whole genome sequencing for this diagnosis. So when you have idiopathic growth short stature, you think about abnormalities that are associated with the cartilage growth plate, which we have seen needs to proliferate and grow. And we can have abnormalities that act within the cartilaginous growth factors, or those that act upon the cartilaginous growth factor, such as growth hormone, IGF-1, and thyroid hormone. Factors that act within the cartilaginous growth plate are primarily those associated with gene variants. A couple of interesting, relatively recent gene variants that have affected cartilage growth plate are the ACAN or ACAN gene, which encodes for aggrecan. It is an abundant proteoglycan in hyaline cartilage, and heterozygosity variant. Heterozygosity is associated with short stature and spondyloepiphyseal dysplasia. Indian hedgehog is essential for chondrocyte differentiation. Variants are associated with acapitofemoral dysplasia. And as we've already mentioned, SHOX, which is short stature homeobox sited on the pseudoautosomal region of the short arms of the X and Y chromosome, and everybody's going to get that on their exam, may be associated, if it's biallelic variants, with Langer's mesomelic dysplasia. If it's monoallelic, with Lehr-Wiley dyschondrosteosis. The latter does not have a whole lot of distinguishing characteristics and is often pushed off as idiopathic short stature until one has run a gene profile. Another interesting set of genes are NPPC and NPR2, natriuretic peptide precursor C, and its receptor. In chondrocytes, this functional unit activates cytoplasmic guanylyl cyclase cyclic GMP-dependent protein kinase that then antagonizes FGFR3 signaling, thus inhibiting the MAP kinase pathway, and we've seen this, and therefore permitting increase in the rates of differentiation, proliferation, and growth of chondrocytes in the growth plate. And we saw in that figure where this was. This system affects glycosylation, protein folding, protein trafficking, and the endoplasmic reticulum. And variants of NPR2 may either inhibit linear growth, as in acromesolic dysplasia, or enhance linear growth. And as we've seen, we can use this material to interfere with FGFR3 induced growth retardation in patients with achondroplasia. Pregnancy-associated plasma protein A encodes a highly specific metalloproteinase that proteolytically cleaves IGF-BP3, releasing IGF-1. Variants of PPA2 are associated with growth retardation and other characteristics. Paradoxically, patients with PPA2 variants, while short, have greatly increased serum concentrations of IGF-1, IGF-BP3, and IGF-BP5, acid labile subunit, and IGF-2. But free IGF-1 variants label concentrations are low because they are attached to IGF-BP3 and IGF-BP5, and the enzyme PPA2 is not functional and does not free them to work at the growth plate. There are variants of shock, which may be seen in a fair number of patients classified as idiopathic short stature. If one does whole exome sequencing, one will find a surprisingly high number of gene variants in patients with ISS. And we are now starting to look at epigenetic changes, i.e. abnormalities in methylation, which also may be of significance in some children with idiopathic short stature. So what do you do with a child with idiopathic short stature after the evaluation and management? Many people, including this speaker, would ordinarily just reassure and observe. Some would treat with oxandrolone, a androgen variant, androgen analog. Others who think that being short is a handicap, but if you ever go to a convention of pediatric endocrinologists, you'll see that the person above 5'5" is unusual in that group when they stand up straight. Every once in a while, you'll see a taller person, but they are easily identifiable. And some people will treat with growth hormone. Some people and some physicians will continue treating. And you can increase adult height, apparently, with high-dose growth hormone, but look at the cost, up to $250,000. My philosophy is I'd rather give that money to the child as a trust fund for his or her education. Unfortunately, that doesn't work too often. So, in idiopathic short stature, therapy with recombinant, as we've said, therapy with recombinant growth hormone, although certainly recommended in patients with growth hormone deficiency, its use in the non-HGH deficient short stature is problematic, I believe. The decision to administer recombinant GH to such a child is based on a shared decision-making approach, assessing each patient's physical and psychological burdens and treatment risks and benefits. Effects on height and psychosocial impact should be readdressed after 12 months of growth hormone therapy, and clinicians should use a restrained dosing strategy. These are the recommendations of Dr. Grimberg from CHOP in Philadelphia and Dr. Allen in Wisconsin, and I would agree with them wholeheartedly, although I would be more wary of using growth hormone in the non-growth hormone deficient subject. So in summary, short stature is defined by gender, age, growth pattern, and growth potential, as assessed by bone age. Evaluation requires thorough patient and family histories, accurate measurements, head, trunk, and limb length measurements, appropriate laboratory evaluation, genetic evaluation when appropriate, selective utilization of diagnosis-specific therapy, and judicious restraint on the use of non-specific growth-promoting therapy. And those are some references. And to show you that some patients with achondroplasia can become famous, here is a painting of Don Sebastian by Velázquez. Thank you for your cooperation and observation.
Thank you, Dr. Ruth. That was lovely. Very informative. I don't see any questions right now, but if anybody wants to ask a question, you can just unmute yourself, or you can type it into the Q&A box. Or I'm sorry, the chat box. We don't have a Q&A box. I would say it's probably best if you unmute and ask directly. I can awkwardly just sit here and smile at everyone.
Thank you. This was great. We have a question.
Go ahead, whoever has the question. It looks like you're muted again.
There you go. Okay. Oh, there's going to be an echo.
If you want to type it into the chat box, I can read it.
There you go. Quick question. I just wanted to find out if there's an age limit for administering growth hormones.
No, the limit is whether the growth plates are still open. You will not get an increase in height or growth rate or adult height if the epiphyses are fused, because there is no more cartilage chondrocytes to proliferate and push apart the ossified parts of the bone, the middle diaphysis from the epiphysis, the end of the long bone. So you have to have an open epiphysis in order for growth hormone to increase adult height, growth rate, and adult height. What growth hormone will do in a patient with fused epiphyses is increase membrane bone growth, such as in the skull. This is why you get the abnormalities of facial configuration that one sees in the adult with acromegaly and a growth hormone secreting tumor of the pituitary. Not an increase in height, but an increase in membrane bone growth.
Wonderful. Any other questions?
I don't believe so.
All right. Well, thank you guys for hosting, and Dr. Root, thank you so much for doing this presentation. It was great.
Thank you for asking me. I'm very happy and wish everybody in Tucson, hope they have a nice winter and come visit Florida. It's nice in Florida too. But anyway, take care.
Thank you.
And thank you. You're going to end this session,